All right, our next session includes a keynote speech that will be done by two speakers, and I'd like to introduce them, Mr. Christopher Coburn and Dr. Patrick Fortune. Mr. Christopher Coburn has served as Executive Director of Cleveland Clinic Innovations and Cleveland Clinic's corporate venturing arm since it was established in May 2000. He has built a high-performance team of more than 60 professionals guided by some of the nation's top venture capitalists. Cleveland Clinic's 52 spin-off companies have raised more than $620 million in equity investments. He is a member of the Mr. Coburn served on the board of directors of Autonomic Technologies, Exploris, I360, Medical, and BioEnterprise. He is a former vice president and general manager of Battelle Memorial Institute, director of the U.S. Enrichment Corporation, and author of the only comprehensive profile of public sector commercialization initiatives, as well as numerous articles and book chapters. He has consulted, testified, and spoken in more than 24 countries. So I would also like to introduce Dr. Patrick Fortune. Dr. Fortune has served as Senior General Manager of Cleveland Clinic Innovations since May 2012. Prior to joining the Cleveland Clinic, Dr. Fortune was a partner at Boston Millennia Partners, where he invested in early-stage companies in pharmaceuticals and medical devices. He has 30 years of experience in the healthcare, life sciences, and information technology sectors. He was previously President and Chief Operating Officer of New Era of Networks, Vice President at Monsanto, Vice President at BMJ, as well as several other organizations. He holds a bachelor's degree from the University of Wisconsin, an MBA from Northwestern University, and a PhD in physical chemistry from the University of Wisconsin. Please help me welcome both Mr. Coburn and Dr. Fortune.
Oh, great. Well, thank you so much for that nice introduction. It's really a delight to be here with my colleague, Dr. Pat Fortune, at this exceptionally well-organized and informative innovation conference. I really have learned a lot from the speakers, and we're looking forward to kind of sharing our experience that we've had at Cleveland Clinic. This talk today touches on the two areas of innovation that so many of the speakers have referenced at Cleveland Clinic. Organizational process innovation and innovation tied to technological improvement. So Pat and I are going to share the podium up here and try to give you some background on both those topics. So as it relates to Cleveland Clinic, we're increasingly a global organization. We have activities in 3 states in the U.S., of course, Ohio, where our home obviously is in our name. We're also in Florida, where we have 1,500 employees in 2 locations, and we operate a tertiary care hospital there. And then recently we have expanded into Nevada. Here in the Mideast, we recently opened up a patient office here in Riyadh. We also have an affiliation in Egypt and then in the UAE in Abu Dhabi. We are operating an existing hospital and building a 4 million square foot new facility. So getting right into organizational innovation, there's probably no issue more significant in American healthcare and really around the globe than cost effectiveness. Bending the cost curve has become a priority as expenditures in U.S. healthcare now exceed 18% of GDP and are growing. So for us, as we look at how to address this, in an organizational structural sense, we in the last 5 years have completely recast our organization into a series of clinical institutes. And these are entities that combine basic functions, for instance, in cardiovascular, cardiology, cardiac surgery, vascular surgery, cardiac anesthesia, all in the same organizational unit, further driving the collaboration among them. Of course, Cleveland Clinic is a group practice model where all the physicians, all the staff, all of us on the administrative side are employees, and that really is in contrast to the classic model in the U.S. I know some similarities here in Saudi, but for us this is a key aspect of our organizational approach. On the organizational innovation side, things that we'd be happy to talk about in the discussion or later are the many, many innovations that are now bringing folks to our campus from around the world, including process improvements, supply chain management, patient experience. Several of the speakers talked about reimbursement in the U.S., in part being tied to scores of patients as it relates to the kind of care they received in the institution. We were one of the first big hospitals to, actually, absolutely the first as it relates to the use of comprehensive electronic medical records. Additionally, several new initiatives underway for us on readmission. The personal access, the patient access to the EMR has been a signature for us. The last few years, we've significantly increased the use of call centers. Just as an example, on the efficiency side, about 5 years ago, the headcount of folks just on our main campus answering the phone exceeded more than 800. We created a call center about 20 miles off of the main campus of 200 folks using state-of-the-art telephony services, and have achieved a really significant return on that one investment over that time. Like a lot of institutions, we're working on codifying CarePass and capturing that electronically. Our facilities management team frequently is in demand around the world. And then in the U.S. system, the management of overlapping interest between inventor, investigator, company collaborators, and even government sponsors is an important topic, and one that we see as a real capability of our institution. So in a moment, Dr. Fortune will be up here to talk about one of what we see as our most significant organizational improvements is our use of metrics and electronic systems to capture and present those. But before he does that, I thought I'd just share a short video of one of our visitors from a couple summers ago who was so struck by his time at Cleveland Clinic, he started to talk about it frequently, including this appearance that was broadcast throughout the U.S. We're not going to get the audio here. Great, thank you.
Or alternatively, we can figure out how do we make the cost of care more effective. And there are ways of doing it. So at Cleveland Clinic, one of the best healthcare systems in the world, they actually provide great care cheaper than average. And the reason they do is because they do some smart things. They say, if a patient's coming in, let's get all the doctors together at once, do one test instead of having the patient run around with 10 tests. Let's make sure that we're providing preventive care, so we're catching the onset of something like diabetes. Let's pay providers on the basis of performance as opposed to on the basis of how many procedures they've engaged in. Now, so what this board does is...
So you get the message that that other guy also said some nice things about Cleveland Clinic as well. But it is these organizational enhancements that really have characterized our institution since its establishment in 1921. And Pat's going to give a quick case study on the use of metrics and electronic capture to manage those metrics. Dr. Fortune.
Thanks, Chris. And thank all of you, particularly KFMC, for inviting us to a truly remarkable event, not just in Saudi Arabia, but I think it's an example of things that are going on around the world that are trying to do some of the same things, including the things we are doing, have done, are addressing problems everybody sees. It would come as no surprise to anybody in this room for me to say that running a hospital of the size of this one or many others in this country as well as others is not a simple problem. In addition to that, if your idea is that you want to deliver superior care and you want to do it in a way that satisfies patients, and on top of that you want to do it in the lowest cost position, that's even harder. So it's very tempting when you see presentations of the kind that I'm about to give, as well as other people, you think about it and say that, well, why don't we just buy the system that that person did, or that person demonstrated, or that person is selling, and then our problem will go away. Well, it's not going to work. It doesn't work that way. It's considerably more difficult than that, and I think one of the things that I'm going to talk about is really a way, which is only one, and illustrate some of the approaches we took in order to be able to move us to the position we're at, which is one from which we need to get better, but at least it's a position that's better than we were a few years ago. Enterprise business intelligence actually has been discussed quite a bit in this presentation, but in this case, I'm talking about enterprise business intelligence is really a management approach, and it's a concept to approaching the kinds of operational improvement we're alluding to in healthcare today, and we do it in context of defining specific processes with specific metrics and methods by which those metrics are tested, evaluated with respect to defining how we're doing and how, in fact, the processes need to be changed in order to do those things better. To continue the quote of use of quotes and the kinds of stuff we've talked about here, it's simply a use of information that enables organizations to best do what they're trying to do. It focuses on operational processes, and it's really an umbrella concept that complements a variety of other management techniques in order to talk about how large, complex organizations that are multifaceted and multi-component can actually be design processes that work together to meet the three kinds of objectives I talked about earlier. Staying with the concept in this conference of quoting Peter Drucker, which has been done several times, if you can't measure it, you can't manage it. So in essence, a key piece of enterprise business intelligence is to make sure that you understand the components of things that you can measure, how you're going to measure them, and actively do it, both to test how far you've come and to define where, in fact, you need to improve in order to meet the objectives, strategic objectives that you've set. It's no surprise, and I suspect, as Dr. Al-Tamimi can tell here, one of the things if someone is suspected of having an MI, will get a troponin will be measured. Blood will be drawn, troponin will be measured. The real question, a question complementary to that, and is that an element in a care pathway, is actually obviously a very good idea. The question is, how long does it take? How long from the time the patient exhibits symptoms, appears at the emergency department, gets blood drawn, troponin measured, and a judgment actually made that impacts clinical care? That's a process issue that exists outside the care path. It's important to know how long that takes if you're really going to measure things to drive the kinds of outcomes other speakers in this series have talked about. The premise of enterprise business intelligence and these kinds of things is then to take an entire organization from logistics, from patient management, from functions including finance and marketing, and break them each into a series of processes that interconnect and interact and in fact are measured in complementary ways, so that one can determine, are they working together, and are they working together well enough in order to drive the measurements that you're trying to actually achieve. One of the ways to do that, and to make it practical and convenient, because it's very easy to get overpowered with how difficult this is to do in complex institutions, is an approach that we have taken and actually have commercialized through a part of the program that when Chris comes back he'll talk about, is the use of performance dashboards. Part of the idea is to reduce these processes and these metrics in a way that one is able to actually look at a single depiction, a single picture of the state of these processes at any point in time, and basically say, are they running well or are they not running well? Not unlike the example of the crashed airliner. Right before that happens, you'd like to know whether systems are operating correctly such that you can correct and avoid it, or you certainly don't want to look at it as was done there after the fact. So what this depicts is really an architecture. If you look at these things department by department and everybody works on them independently, you'll actually get some benefit. The problem is that the nature of an institution like this one, the processes interact. Care is delivered in order sets that contact imaging, that contact pharmacy, that contact nursing. If all of those things don't work together and come in some kind of consistent way, the fact that each of them might work well individually doesn't really help. So that or at least it won't be optimum. So the idea behind an architecture is to define a consistent approach that's going to be used across all operating centers, including functions within the hospital, whether it's finance, billing, or patient registration. All of those things are defined in context of a single framework where the various kinds of things, whether it's financial operation and operational statistics, quality performance, patient access, and the operational dashboards that are required to define whether or not the process you're operating through at any point in time is cost effective or is in fact needs to be improved in a particular way. This is an example of an implementation within one of our community hospitals off of the main campus that looks at adherence, first deviation from, and then progression to adherence to a particular pain management objective that was set as part of this hospital's both strategic and operating plan. This is reviewed on a quarterly basis, as I'll describe in a second, and in each review you want to look at where you are with respect to the goal that's been set, use the dashboard to highlight where you're missing, and then use that same dashboard to articulate the ways in which you need to move in the next quarter in order to define how you're going to bring the curve you're at closer to or in excess of the target that you've already set. Each quarter, as I said, the operational reviews of the hospital are structured around a common quarterly review process in which clinical administration leaders actually look at the individual dashboards. And the kinds of things that are measured on these dashboards are as granular as they need to be in order to make sure that the performance of the hospital is meeting the objectives that you're actually saying. And it can talk about a lot of things. If you're trying to manage diabetes, which is a high-cost chronic disease, then measuring HbA1c every 6 months and adhering to that guideline is an important thing that you really need to be able to do. How many of the patients that are diabetic, diagnosed as diabetic, and are under care did not get an HbA1c measurement in the last 6 months? Understanding that's important in containing cost. If you are trying to manage on a completely different end, how much it costs to do a heart transplant, you have to track what drives the cost of heart transplants. In particular, it's important to measure the differences from surgeon to surgeon and period to period, adjusted for severity, for the amount of blood you're using is being transfused in each process. Those two examples serve to illustrate the large macro effects that you need to measure, as well as how micro you need to be if you truly want to be a low-cost producer. This can be looked at, as I said, architecturally in a lot of ways, and you can see on this slide how it starts with individual functional systems by organization, methods by which the information can be acquired and can be put into a framework using something like a data warehouse, so the dashboards can be prepared, but more importantly, they all have to feed the management control system. That means the content of those dashboards are being looked at every quarter or more frequently perhaps, and in fact, behavior is being adjusted based on what those reviews say. Recognizing that where we are, and in point of fact, where we are is a place that we know we've got to get better from, even though we think we're a lot better than we were 5 or 10 years ago. It's also important to realize these things don't happen in one step. It's not like you can take an institution this complex with the kinds of patients you need to treat and say, I can do this in one fell swoop. You have to start in a granular way. It'll take time to get information systems built. It'll take time for electronic medical records to get formed, for order sets, CPOE to be implemented, and individual departmental systems to actually be implemented. But it doesn't mean you can't begin the journey to the kind of things that we described. If you have to start with paper, whether it's checklists or whether it's individual reports, and whether it's more important that the workflows and the care paths be defined than it is that you've got all the information electronically. As was discussed earlier, if you can get it just in time and electronically and affect point-of-care clinical decision-making, that's even better. But you may not be there for a while. And in fact, not being there is not a good reason not to start. So the important thing in our view is to think about this in stages, which is exactly how we went about it, understanding what the care and efficiency objectives are, defining the workflows and defining the care paths that are going to get you there, define the metrics, and then measure, measure, measure. And on a general repetitive basis of applying those rules, the ability to move the organization to adhere to the kinds of strategic objectives you've set for therapeutic effectiveness, patient satisfaction, and low-cost position is an achievable objective. Thank you. Chris?
So now, talking about the technological innovation component at Cleveland Clinic, and I'll try to say a word about the commercialization of the dashboards, which initially was 12 of those we put into a spin-off company that was acquired by Harris. So first, where do we start from? So, looking back over our journey, I think in the year 2000, we'd really view that as the inflection point. Cleveland Clinic, established in 1921, innovation always important from the beginning, but as an organizational commitment, something we created a unit. I was recruited into the clinic to establish that. It really dates to the spring of the year 2000. Prior to that, Cleveland Clinic had never had a technology spinoff, had a few licenses, no standing in the venture community, and really was not a player, if you will, in contrast to its great clinical leadership. So today, this is kind of a scorecard, somewhat long, but we like to believe we are producing some important outcomes for the institution, but also for patients. Included in that is now 55 spin-off companies. Those companies have raised about $700 million in equity financing. In our view, that's the marketplace voting with its wallet about the potential of these technologies. An important topic, and I think touched on a little bit by some of the prior speakers, including KFMC leadership, is that we share commercialization revenue with our employees, so much so that more than $60 million has gone to them over time, and that number is increasing rapidly. And then again, we've had a pretty significant job creation. One of the most substantial of our recent innovations from an organizational standpoint is the creation of this National Innovation Alliance. In this model, we are stitching together large providers in the U.S., the biggest provider in the state of New York, the biggest in the Mid-Atlantic region, one of the largest in the state of California, into a national system. We are enabling that by posting employees of Cleveland Clinic, of our office, in these institutions to help drive their innovation and commercial application systems. And we come in typically as the guest of the leadership, frequently the CEO, who are thrilled to get our years of learning, all of our systems, really the lack of risk on the very day that we show up. So, and you can see the names of some of those institutions. We expect to be in more than 15 institutions in the next 2 years, and that we'll be operating in more than 20 states in that system. We have a little bit of activity overseas, a joint venture in Dublin, and who knows, maybe in other parts of the world. So we started this march by asking the most important question: why do we care about this? Why should an organization that was established to provide care to patients, do research on their illnesses, and teach those who serve, what does commercial application really matter? And again, I think refreshingly, several of the speakers have touched on this in prior talks. In the end, it's about helping patients, but it's also about attracting and retaining the best staff, providing them the kind of challenges that motivate them. It's securing resources. The dollars we generate go back to support research in our institution. And then we also feel that we have an economic stewardship responsibility for the cities we're in. Cleveland Clinic is the largest employer in the history of Cleveland, second largest employer in the state of Ohio today. So we created a structural element that today expresses itself in 4 units. 1, to drive the creation of technology. 2, to do transactions around those, create companies, do licenses, secure funding. Another 1, to provide strategic consulting to our internal clients on a selected basis, external, and then finally this alliance program I talked about. Interestingly, we also have a medical innovation gathering. This is we are in our 11th year. We get about 1,200 registrants from 15 countries and 35 states. We've had the CEOs of 2/3 of the largest medical products companies. You can see some of them there. Over 50 of the top venture capitalists in North America and Europe, heads of the FDA, CMS, U.S. senators, governors, and over 100 entrepreneurs. I also can't help but note, we also have a giveaway, strategically timed to help people stick around. We give away international travel for our attendees there. But also, again, keeping some of the themes that you've already seen, we work hard to engage our innovators, whether it's having them attend and learn from sessions like this, or it's straightforward, very practical workshops, 2-hour sessions that we offer around our campus over a period of a year, and then we restart and go again. You can see some of the titles here. Another piece of our innovation approach is, for 7 years, we've been interviewing 100+ of our top clinical leaders and asking them what they see as the breakthrough technologies in their own discipline, and then synthesizing that down to a list of 10 that we release and gets picked up around the world. Recently, we've started to ask those same clinical leaders what they view as the unmet needs in their field. So we have a highly differentiated model for our work at Cleveland Clinic. Many aspects of it are there. We have our own investment arm. We are also strategically linked to a whole set of venture capital funds. We have a terrific facility, a 50,000 square foot building, 2 other buildings on campus we keep spin-off companies in. We are working on building a 3rd. We try to mimic industry as much as we can in terms of doing IP development. We'll pull together a series of clinicians. Right now we're in a project with our urology department where we use a facilitator and a lot of pre-work to try to get from them the same insights that they might share with industry leaders and create products around that. We have a product development arm as well. So looking at us in just a quick snapshot, maybe the most important thing for us of all is the alignment that exists inside of our organization from top to bottom as it relates to the importance of innovation and its ultimate application to benefit patients. We benefit greatly from the fact that our CEO, Dr. Toby Cosgrove, is one of the most prolific inventors in the history of Cleveland Clinic. He was a cardiac surgeon. We like to refer to him sometimes, even when he's around, as our innovator-in-chief. This year, we'll have about 290 inventions just on the main campus. That's a 30% increase and represents an all-time record. So we do feel like we have some momentum. I said earlier, we share with our inventors, our innovators, 40% of the net revenue we generate goes to them. And finally, our team of 67 includes folks like Pat, who not only was a venture capitalist, but was at the officer level of 3 giant medical products firms. So if you can see that, no surprise in an organization led by surgeons that devices would dominate for us. But I think the news in the U.S., and again, reflected very much in the agenda that the organizers put together, is the growth of health information technology. It is absolutely on fire, both inside our own portfolio, but also in the industry and the investment community in the U.S. So the 55 companies, if this slide is legible to you, you can see the distribution, heavily device-oriented, but then in the recent growth in the light shaded rectangles in information technology. Additionally, if you can make out the slide, it gives you a sense for the stage of the companies. The HIT ones are the ones moving most quickly. We probably have half a dozen companies that are closing in on monetization, a sale in the next probably 18 to 24 months. So quick example of one of our companies, Autonomic Technologies, Inc. is a tiny implantable neurostimulator that sits behind the nose, above the roof of the mouth, stimulating the sphenopalatine ganglia, the SPG, to provide near instantaneous relief to headache sufferers, clinically approved in Europe for cluster headaches. The migraine trial is underway. Our co-investors in this include some of the titans of the industry, Kleiner Perkins, Novartis Ventures, and others. So this will be game-changing technology, assuming it gets all the way through in the U.S. 16 million people a year in the U.S. seek care for migraine headaches. On the big data side, Explorus is about a 100-employee company, or will be shortly, that has a Google-like search engine that allows near instantaneous, less than a second searching of unstructured records to find correlations that really were not possible. Explorus has become one of the hottest HIT companies in the industry in the U.S. And then my last slide, I noted before, our National Innovation Alliance. Who knows, it may increasingly become an International Innovation Alliance. Thanks so much for having us.